us for our first case, where we discuss a patient with a mild cataract and dry eyes who has very good best corrected vision. The challenge really here is determining whether we operate. And this is a patient that I saw last year, a 70-year-old female with decreased vision, particularly in low contrast settings. So she really struggled reading a menu in a dark restaurant, that kind of thing. She also complained of glare and light sensitivity. Now, when I examined her, she had mild cataracts, just 1+ of nucleus sclerosis. She also had significant dry eye, so it was difficult at that point to ascertain how much of it was the cataract that was causing the visual problems and how much of it was the dry eye, because we know that dry eye can cause glare, light sensitivity, and reduced vision in dim settings. So at this point, we did a thorough examination. We checked her vision and her refraction, and she was actually achieving best corrected vision of 6.5 and N5, which was very good. So we had to think long and hard before we proceeded with cataract surgery, but the patient was very motivated and was extensively counseled. So she understood the fact that performing surgery may still leave her with some of those symptoms. So what did we do next? We treated her ocular surface. So we gave Aeon Protect Plus. We prescribed a short course of FML, which is a mild steroid, gave Omega tablets, and extensively counseled the patient. I chose the RayOne EMV lens because I know it's a lens that's very well tolerated by patients. And I targeted plano in her dominant eye, her left eye, and -1 in her right eye. So these are actually her biometry screenshot and topography or pentacam scan. Purvi, what do you think of the reliability of this scan? Because that's something we always look at.
We do. So actually we carry out the biometry, then we always follow that up with a pentacam topography or topography of some sort. And we look to make sure that the astigmatism, the corneal astigmatism matches on both. So it's just to get a double view to make sure that they correlate with each other. So with this patient, as you can see, the amount of astigmatism is pretty low in both the eyes. And looking at the pentacam tomography, it's a good scan, there's nothing flagging up. And again, the amplitude of astigmatism is pretty low. The degree of the axis tallies up quite well. So we know that's quite an accurate reading.
Thank you. Yes, I was happy with the topography and the pentacam, and the patient did not need a toric lens, which simplified things.
So if I run through the results, because Masara, you don't like to blow your own trumpet, but this patient had an absolutely phenomenal outcome. So binocularly, she was 6.4 unaided. Her near vision was N.5 and intermediate was N5. So across all distances, she had absolutely excellent vision. And then we looked at her refraction. The right eye, as planned, came out as -1, as you'd hope for, and the left eye was pretty close to plano.
Yeah, she did really well, really happy with the outcome. We achieved better vision than we had preoperatively, and the main thing she said actually was that she really found the improvement in the low contrast setting, even with the blended vision. So really good case, and really pleased with the outcome. So the EMV lens by Rayner provides patients with an excellent range of vision. It's an enhanced monofocal lens. It has no diffractive steps or rings within the lens design, and it uses induction of positive spherical aberration to increase the range of vision by 1.5 diopters. It maintains excellent contrast sensitivity. It has a similar dysphotopsia profile to a monofocal lens, and it provides patients with a natural blend of vision between the distance and the near eye.
We're done?
Yeah. Wow. I'd like to correct you, her vision was actually 6.4 for distance post-op. You can
to repeat that?
You can take
the
that
vision.
out. No, I'm only joking. That's only joking.
No, it's true, that's irritating. It was 6.4.
I was just teasing you there. That was quite funny.